Bismillahirrahmanirrahim. Thanks for Ain Shams Clinical Oncology Department for invitation for this sessions in brachytherapy. I have the honor to introduce our professor, Dr. Amin Sayed, to talk to us about radiobiology in brachytherapy.
Bismillahirrahmanirrahim. Good morning. In the beginning, I want to thank Dr. Ehab and all the organizers of the committee for inviting me in my second home in Shams University Radiation Oncology Department to make this presentation. And I hope to be with them always in every event. Today, inshallah, I'm going to make a very short presentation about some radiobiological aspects in brachytherapy. We all know that radiobiological principles are increasingly well understood for external beam radiotherapy for a variety of tumor histologies and associated normal tissue effects. Let me remove that mask. It is far more difficult, but equally vital, to apply this understanding in the daily usage of brachytherapy. The transition from low dose rate to fractionated high dose rate brachytherapy and pulsed brachytherapy treatment has highlighted the difficulties in applying radiobiological principles to brachytherapy. The biological effect of dose absorption in brachytherapy is influenced by factors, so many factors actually, such as total dose rate distribution, not only dose rate, but dose rate distribution. This is very important. Dose per fraction or pulse, time interval between fractions or pulses, the overall treatment time, radiation quality, therapeutic intervention like hyperthermia or chemotherapy, factors related to the patient himself, and factors related to the tumor like hypoxia. In brachytherapy, there are a variety of techniques used, all of which are generally defined by the dose rate provided. These include very low dose rate, which is less than 40 centigrade per hour, low dose rate, which is less than 2 gray per hour, medium dose rate, which range between 2 gray to 12 gray per hour, and high dose rate, which is higher than 12 gray per hour. And of course, pulsed brachytherapy, which completed in 3 to 4 hours. However, modern day brachytherapy is more often classified into two categories: high dose rate brachytherapy and low dose rate brachytherapy. High dose rate is applied in catheter-based procedures using non-permanent radioactive sources that complete treatment in minutes. But on the other hand, a low dose rate is finished in a longer time than that. Pulsed dose rate was developed to deliver multiple small high dose rate fractions during a very short period, range between 3 to 4 hours, in order to catch more DNA lesions prior to repair, producing biological effects similar to conventional low dose rate treatment. Within the range expected to encounter, the clinical change in dose delivery rate has a significant impact on cell survival. The effectiveness of radiation for more tumor types irradiated in vitro decreases as the dose rate is reduced between 1 centigrade per minute, as evidenced by the classical colonogenic survival curve. All the known factors that affect cell response to irradiation, including the 4+1 Rs, are likely to have an influence on both tumor and normal tissues. However, throughout different brachytherapy protocols, the ability to repair DNA damage and the possibility for re-oxygenation are expected to display the most variability. The 4+1 Rs of radiobiology: repair, re-oxygenation, redistribution, repopulation, and radiosensitivity. Some people like to add another R, which is rate of delivery, to be 6 Rs. Repair, the majority of repair occurs within the first few hours after irradiation. Therefore, the interval between fractions will have no effect on the degree of repair unless a very short period is employed between fractions, as in pulsed dose rate. Redistribution, because of the clonal heterogeneity of tumor composition, there is unlikely to be any significant clinical consequences of redistribution based on the interval between fractions. Repopulation, the process of repopulation is generally occurs after 2 to 3 weeks and is considered insignificant in most brachytherapy fractionation systems. Re-oxygenation, the process of re-oxygenation may occur rapidly. However, complete re-oxygenation after large single doses may not be effective as multiple small fractions. Radiosensitivity effects is, if present, it's not always present actually. If present, are more likely dependent on number of fractions and or dose rates than the interval between a fraction. Because the effect of repopulation begin after a few weeks of treatment, it is critical to avoid taking a long gap from treatment before starting brachytherapy. We have to start brachytherapy in a very short time to avoid repopulation. Treatment with brachytherapy can be provided before external beam radiation therapy is completed, and it is essential to consider the cumulative dose of radiation to the tumor and normal tissues on a daily and weekly basis in these circumstances. The BED and EQD2 formulae can be used to calculate the dose from the two techniques. To ensure enough time is allowed for repair of sublethal damage in normal tissue, it is not advised to administer both external beam radiotherapy and brachytherapy. The BED equation, BED is the biological equivalent dose, not the biological effective dose. It is biological equivalent dose. The linear quadratic LQ model is the most commonly used tool to estimate the biological equivalent dose, BED, adjusted for dose rate, dose per fraction, and overall treatment type. Its goal was to illustrate the effect of changing fraction size on the likely effectiveness of the new fractionation scheme. It was derived only as a tool to estimate such effects and was never intended to be used to prescribe clinical, actual clinical dose. This is the equation by which we can calculate BED, which is depend on the number of fractions N and fraction size D, and of course, the endpoint specific parameter quantifying the sensitivity to change in dose per fraction or dose rate, which is alpha over beta. The above BED equation, however, does not account for the effect of repopulation. Although the repopulation effect may be negligible for treatments less than 3 weeks in duration, it can be significant for a longer treatment, especially permanent low dose rate implant. And this is an equation corrected for time overall treatment time effect by adding or actually by subtracting a terminal, which is depend on the overall treatment time and the potential doubling time and the starting time of repopulation TK. TB represents the potential doubling time. TK is the delay until repopulation starts, and T is the overall treatment time. This is the factor which is subtracted to account for the repopulation. The equivalent, the biological equivalent dose for 2 fractions can be calculated from BEDF, which is given above, and we can convert the BED into a biological equivalent schedule equivalent to the 2 Gray or the conventional 2 Gray fractionation schedule. This conversion generates doses that are comparable to those seen using conventional 2 Gray pair fractions, which is given by this equation. This equation can be used when the external beam radiotherapy and the brachytherapy are being employed in order to generate a composite dose for comparison. In continuous irradiation, the equivalent dose in 2 Gray fractions is estimated as EQD2 by adding a factor called G. This take into account the all radiobiological factors which may occur during the protracted overall treatment time. This factor G is given by this equation, which is depend on the potential doubling time or the potential half-life or half-time for repopulation. EQD2 for very short delivery, when T is much less than T half, G is approaches 1. In this limit, the dose rate effect disappear, and the ISO effect formulae become identical with the one that governs the external beam radiotherapy. For very protracted delivery, which means very low dose rate, G tends to 0. There are concerns regarding the validity of LQ model at very low and very high dose per fractions. Although no definite limits can be stated, it is felt that the LQ model is useful for dose per fraction ranging from around 1 Gray to about 5 to 6 Grays. Above 6 Gray or below 1 Gray, it cannot be applied. As the low dose per fraction, low dose hyper radiosensitivity may may mean that LQ model will underestimate the actual biological effect. At high dose per fraction, there are data suggesting that the LQ model may overestimate the biological effects. This overestimation is likely to be more pronounced for endpoints characterized by low alpha over beta values, especially in prostate. Difference between the EBR, the external beam radiotherapy and brachytherapy. The dose per fraction, dose rate, and treatment time are essential parameters that differ in temporal distribution of both external beam radiotherapy and brachytherapy techniques. Another major difference between the external beam radiotherapy and brachytherapy is the level of homogeneity of the generated distribution. This is a very important factor and should be taken in account during the treatment planning, which is a key aspect in the radiation effect. The goal of external beam radiotherapy is to deliver a dose that is homogeneous as visible throughout the planning tumor volume, planning treatment volume, with variance range from 95 to 107%. On the other hand, the brachytherapy is characterized by high heterogeneous dose distribution even in small target volumes due to the rapid and continuous dose fall close to the radioactive sources according to the inverse square distance law and the effective absorption of the dose by the tissues. The entire CTV receives a minimum dose, and on the inside it receives a larger dose and dose rate in the vicinity of the radioactive sources for a large portion of the volume. The gross tumor volume can receive up to 150% of the dose delivered to the CTV periphery, resulting in a significant dosage and dose rate decline. In fact, the biological effect increases significantly as a result of high heterogeneity. Only a uniform dose distribution or dose time fractionation at a specific reference point are covered by the simple LQ formalism. This means that when we do LQ calculations, it could be calculated for a point dose or for a uniform dose distribution. For external beam radiotherapy, since most delivery strategies aim for a uniform dose distribution in the target volume, this may be reasonable approximation. With modern conformal delivery techniques such as intensity modulated radiotherapy and rotational delivery techniques like VMAT, those will vary as a function of location within most organs at risk. The same is generally true for brachytherapy dose distributions. To overcome the difficulty of the addition of external beam radiotherapy and BT dose distribution, we have to know that such difference in a spatial and temporal dosimetrical distribution, the external beam radiotherapy and brachytherapy make the addition of its dosimetry contributions to the total dose distribution is very complex process. Furthermore, while the register of image studies from external beam radiotherapy and brachytherapy phases can be used to perform this sum, the changes in the patient's anatomy throughout the treatment complicated this process. It's not easy to add the two images together because of that change in anatomy. Understanding all the above distinctions, radiobiology offers us with the necessary tools to calculate the contribution of each therapy phase. The commonly accepted practice to compute the cumulative sum of the dose delivery by the external beam radiotherapy and the brachytherapy implies the assumption of several approximations which make this task easier. The volumes or point of interest in the brachytherapy phase are considered to be irradiated uniformly. This is a very important point by the prescription dose of external beam radiotherapy. This assumes that there is no area in the organ at risk which is irradiated by a dose lower than that prescribed in the external beam radiotherapy phase, which represents a conservative scenario for the organ at risk. And it is also more reasonable for the target, since the CTV for high dose rate defined in the brachytherapy is a subvolume of BTV defined in external beam radiotherapy. Therefore, the summation of the contribution of the two phases of the treatment is based on the mere addition of the doses of the brachytherapy phase in the point and volume of interest, plus the prescribed dose in external beam radiotherapy phase, being both previously converted to their equivalent in 2 gray per fraction, a process usually known as parametric sum. This strategy facilitates the use of linear quadratic model, LQ, to perform the assessment of dosimetric distribution of the of external beam radiotherapy and brachytherapy. Thank you very much.
Thank you to our dear Professor Dr. Amin for this scientific talk. Is there any question from the floor? Well, I have a question for you, dear Professor. From a radiobiological point of view, is there advantage in the arrangement of brachytherapy and external beam? I mean, if the case suitable, can I give brachytherapy first and then external beam radiotherapy? Radiobiologically, will be a benefit from that?
Do you mean that to start with brachytherapy?
Yes, when it is possible. يعني tumor residual قليل ممكن هل ابتدي بالبراكي؟ هل ده radiobiologically ممكن ليه benefit?
I didn't see any trial like this before, but actually I think we usually start with external beam brachytherapy to cover a larger volume, but in brachytherapy we cover only a very tiny volume. We cannot cover the whole volume which should be irradiated.
Actually, I read it in just ongoing trial. لسه حاجة جديدة يعني بيفكروا فيها. فقلت استفيد من رأي حضرتك radiobiological، هل ده يفرق معايا مثلا في التوكسيستي بتاعة
هو في
bladder doses؟
At the moment, there are some trials to give them in parallel. Like I said in my presentation, that we can start brachytherapy with or during the external beam radiotherapy.
Simultaneously, yes.
Yes, simultaneously, yes. But before, I don't believe in that actually. Yeah, it may be a trial at the moment, but I don't.
Is it possible for the panelists to talk or as well?
So,
Dr. Huda with us.
Yes, no, because I think Dr. Amin, hello, Dr. Amin.
hello, Dr. Hoda, how are you?
Oh, fine, thank you very much. Professor Amin is obviously our tutor in radiobiology, so I'm very, happy. Can I just answer with you that question, because obviously the question is more clinical.
Yes.
As to whether you can start with. I think there are two issues here. If you're talking about endometrial cancer, so you're giving adjuvant treatment with a vaginal vault brachytherapy, it is possible to give vaginal vault brachytherapy first. But like Professor Amin just mentioned, it doesn't make sense to start with brachytherapy. You need to start with for cervical cancer, because you're obviously giving brachytherapy for advanced, or giving external beam radiotherapy and brachytherapy for cervix cancer when it's an advanced disease. So it makes more sense to cover a bigger area. And once the tumor shrink, then in that case, you can give after that brachytherapy. And when you sandwich them both together or give them simultaneously, then you're actually using that only in the last week or two of the radiotherapy, and not even from the beginning, because otherwise you'll be stuck with a very large volume.
Okay, thank you, Professor.
Thank you, Dr. Had.
Okay.
Yes, Dr. Ayab.
I think also in cases of cancer prostate, sometimes, especially in the low-dose rate brachytherapy era, they was giving first the brachytherapy and then the external beam radiotherapy, because in this case we're just dealing with small volume. This is a prostate only, without irradiating the lymph node. So in this case, they give low-dose rate brachytherapy first, then after that they give external beam irradiation. So it is possible if we don't concern about irradiating the lymph node, because in this case we have to take into account the radiation dose to the surrounding normal structure, especially rectum, sigmoid, colon, and renal bladder. So if there is small volume, like in cases as endometrial cancer after surgery, or in case of prostate, if we irradiate only the prostate, we can give the brachytherapy first, then followed by extended beam irradiation. Thank you.
Thank you, Dr. Ayab.
Again, I would say in this case, you're actually giving the brachytherapy only in prostate cancer. So if you're giving low-dose rate brachytherapy, it's not given in conjunction with external beam. So you're giving low-dose brachytherapy only as a sole treatment. So if the patient relapses in the future, then yes, it is possible to give radiotherapy to the pelvis, but it's not as a one regimen. And I think your question was, could I start, if I'm actually going to give radiotherapy and brachytherapy, can I start with brachytherapy first? Am I right?
Yes, Dr. Wood, okay.
Yeah. So I think what Professor Ihab was talking about is if you're actually giving prostate brachytherapy as a low dose rate, you give that not first, but you can give it as a sole treatment. That's the only treatment if you're giving it as a low dose. But then you can follow that with external beam radiotherapy if the patient relapses a few years later in the lymph nodes, but not as a one regimen. You can't give the brachytherapy first in that case.
Okay, two blends, okay. Thank you, Dr. Hood.
Thank you.
Thank you, Professor Amin. Thank you.
Okay, next talk is will be physics and brachytherapy. The speaker will be Mr. From UK. Yes, Mr. Andrew Brown from UK. The talk is physics and brachytherapy.
Good morning. My name is Andrew Brown, talking to you from Bristol in the United Kingdom. So I'm going to talk to you this morning about some of the aspects that we think about in the physics of brachytherapy. It's quite a large subject, but I will try and cover all the main points. For your information, in Bristol, we use a variant gamma med high-dose rate afterloader with the Eclipse Brachyvision planning software. And we currently treat prostate, gynecological, esophagus, and skin with brachytherapy. Any images that I show during this talk are for illustration only, and I'm not recommending any particular manufacturer or equipment. So very briefly, I will just touch on the very basics of the radiation physics. We'll talk about the different types of brachytherapy source, different isotopes, and then go on to think about how we calculate the dose for brachytherapy plans, and then some of the radiation safety aspects of treatment. So very quickly, just to remind ourselves, so unlike our linear accelerators, which we use to treat external beam, we are using radioactive isotopes for brachytherapy, where we have an unstable nuclei which like to decay into more stable daughter products. And in that process, they release other energy as either a photon or other particle. So either the electron, if it's a beta decay, a helium nucleus if it's alpha, and a gamma ray. And the emission, it is dependent on the atom that is decaying. So important concept of radioactivity is the half-life. So the half-life being the period over which half of the atoms within a sample have decayed. And then this property changes from isotope to isotope. The activity is the rate of decay of the atoms in your sample, and then we use the units of Curie and Becquerel as measurements of activity of a sample. So the Curie, named after Marie Curie, who discovered radium, is the equivalent to 3.7 times 10 to the 10 disintegrations per second, which happens to be the number of disintegrations in 1 gram of radium. So a source that is more active is having a higher rate of decay, so a higher dose rate. And also importantly for brachytherapy is the concept of an inverse square law fall off of dose. So you have a point source for brachytherapy, you have a very rapid fall off of dose. Whereas for teletherapy, where the patient is at a larger distance, typically 1 meter away from the source, the fall off due to distance from the source is relatively shallow. Whereas if you've got a source within the target, as with brachytherapy, you very quickly have dose fall off. So it's a very dominant aspect of dose distribution using brachytherapy sources. So we categorize brachytherapy dose rates into these broad categories. We tend to mainly talk about low dose rates, which is under 2 gray per hour, and a high dose rate source, which is generally greater than 12 gray per hour dose rate. Pulse dose rate is a way of trying to simulate the radiobiological effect of a low dose rate treatment, but with the advantage of being able to use the high dose rate afterloader and source. So the radiological response of your treatment very much depends on the dose rate that you're using and how that affects repair. So how you deliver the treatment will have an effect and has to be considered. So when we're choosing our isotopes that we're going to use for brachytherapy, we have to think about various things. First of all, we might think about the energy of the daughter products. So what the energy gamma ray is being emitted. Is it emitting alpha particles or beta particles? Because if you have an isotope that's emitting a useful gamma photon, but is also producing unwanted alpha, you might need to encapsulate that source within some shield that can filter out the unwanted alpha particles, but allowing transmission of the photon. There's a balance between half-life and activity, with longer half-life sources tending to have lower dose rates, and vice versa. And especially with the if you have a really a long half-life source, has the advantage of not needing to be replaced as often, maybe, and you get more life out of the source, but also you might then end up starting off with relatively high dose rates, but after a couple of years having much slower dose rates, and therefore changing either the radiobiology of the treatment, or slowing down your treatment times, which is important clinically. By ease of use and radiation protection, we mean that is it easy to transport, install, and just generally keep secure, and can it be used easily in a treatment? And also importantly, do you have a ready source of your source? So can you easily procure the isotope at a reasonable cost? So the most common HDR source that is used today is Iridium-192. It has a half-life of almost 74 days and a photon energy around 0.4 MeV. It's classed as a high dose rate source and is also used in pulse dose rate treatments. Typically used in high dose rate treatments as a small pellet on a wire that can then be loaded within an afterloader and then moved into the treatment site through an implanted applicator, catheter, needle, etc. Cobalt-60 is another source that can be used for high dose rate. It's much longer half-life, meaning it is only required to be replaced much less frequently than the iridium source that has some advantage. The photon energy is different to the iridium, so it's almost 4 times higher energy, and is generally less commonly used for high dose rate. Iodine-125 is a popular isotope for implanted seeds for a low dose rate treatment. So there's still popularity for prostate implants using these iodine seeds, which come supplied either as separate seeds or as strands of seeds. So much lower energy than a high dose rate sources. So here's just a diagram of how the iridium and the iodine sources are often supplied. So importantly then, how do we calculate the dose to our patients using brachytherapy? So we have to use different methods from the external beam treatments using linear accelerators. So when brachytherapy was first developed, the early pioneers came up with standard dosimetry systems, which allowed for the standardization of the source distributions So working out length of iridium wire that was used, or how much radium you would load into an applicator and in what relative weightings within the applicator, for instance. So this helps you standardize your treatments, but also give you consistent data to be able to make some sort of analysis of your treatment outcomes and be able to compare your treatments and communicate with other centers. So a couple of examples of dosimetry systems used in brachytherapy. The Paris system was one of the systems used for arrangement of iridium wires. This consisted of specifying how you would lay out a geometric pattern of the wires and specify the spacing and the length of the length of wire required, and then would specify these basal points, which were central points between the axis of the source wires, as you can see in the diagram here. The Paris system is still found for, say, breast implants, and you would see a breast implant, even if it is now using catheters and iridium high dose rate source, practitioners would still be implanting using this kind of geometric arrangement, using a template through the breast. Another standard dosimetry system was the Manchester Gynae system, which was one of the earliest brachytherapy systems for gynecological cancers, or for cervical cancers. And this used an anatomical reference system of different points that would specify how you would load originally a radium field applicator, the combination of sort of radium and wax and things, and how you would load relative amounts of radium within that applicator. Then you could then prescribe your dose to an A point, as it's called, which is 2 centimeters superior and lateral from the cervical os in this case. And this is very important in a time before 3D imaging. So we've now moved on in modern practice from needing just a standard dosimetry system. Now we have 3D imaging, such as CT scans and MRI scans. We can visualize our organs that we're treating, our targets that we're treating, and the organs at risk that we're also irradiating. So it requires more sophisticated dose calculation algorithms to work out the dose using computer systems. So the most commonly used calculation at the moment is this task group 43 formulism from the American Association of Physicists in Medicine. And this is to allow us to calculate the dose rate to water at a given point. And then within the treatment planning system, the algorithm within that would then calculate for each voxel point within the plan. It would calculate a dose rate from all the source points within the plan to then build up an integral of the dose and be able to reconstruct a 3-dimensional dose matrix, and then we can display and view our dose volume histogram using that. So this algorithm, this calculation, just looks at things such as the distribution of the radioactive material within a non-point source, because even when we talk about point source, there is a non-point source aspect of the physical sources, and it looks at things about the angle at which you're taking the dose rate from the source and the internal shielding of the source, and things like that. So the problems with TG43 is that it is just a calculation to water, and it doesn't account for differences in the tissue and inhomogeneities within the patient. And likewise, it doesn't account for the material of your applicators you might be using and any other shielding that you require or need. So if you were to want to account for these things, you would need more advanced calculation methods to give you that accuracy. And there are things such as Monte Carlo, but also more advanced algorithms that are now available in modern treatment planning systems. I'm yet to get my hands on Varian's Acros algorithm, but that is one way of looking at these things. So for instance, looking at this dose distribution of a standard Manchester pair isodose over the cervix tumour, even though we get the doses displayed in a nice pear-shaped distribution, because of the slight differences in the applicator material and the tissue, in reality the dose distribution isn't quite as perfect as that. But saying that, TG43 is pretty useful, because within standard treatments such as prostate and gynae, the tissue in question is fairly water equivalent. We're not going through bone or large amounts of air, like lung, or large blocks of metal or artificial hips and the like. So it's not a big issue necessarily. But when it comes to things like using certain skin applicators that use high density metal shielding, TG43 wouldn't give you an accurate enough result, and you would have to use other Monte Carlo data to give you that, or standard plans derived from Monte Carlo data to be able to do such things without a more advanced algorithm, because the scatter conditions from the metal applicator, the high Z shielding, and the lack of material around the surface of the skin, which is just air, it's obviously less accurate again. So another aspect of the physicists have to think about is the source calibration, and ensuring the sources that we take delivery of are as expected. So whether that be the seeds for low dose rate treatment, or iridium or cobalt high dose rate source, would have to perform assays or some sort of calibration check against what the manufacturer supplies. They'll supply a certificate with expected activity for the source. And then when we install a new source, say for a high dose rate, we will use this well chamber to have a measurement of the air Kerma rate from that source, and it should agree within 3% or so. It tends to be within 1% of what the manufacturer specified number is. Other important things for the physicists to think about is the radiation safety involved in handling these radioactive sources. So unlike with the LINAC, that once you turn it off, the radiation stops, our brachytherapy sources are always on, and we therefore have to treat them with with that respect. So obviously security of the source, whether you need sort of locked cupboards, security doors, alarms, and the like, other security methods to secure them. You'll need to have special calculations for the amount of shielding required for the equipment, or does any of the operators or anyone handling the seeds say you've got to assess the dose that they would be receiving to fingers and eye dose and body dose, etc. If you're using the source or during treatments, it's a good idea, for instance, for staff to have dose monitoring with some sort of independent dose monitor that can alert if there's the source is out whilst the staff are in the room, or the staff is receiving an unintended dose. We'll have to specially train staff for handling radioactive sources. Importantly, doing the appropriate QC on any equipment, for instance, the afterloader and associated safety interlocks are very important. And there will be any, you'll need to make sure you're compliant with any local regulatory issues that will be dependent on where you are and what the rules are for storing and handling and disposal of the radioactive sources are. But yeah, that will be dependent on your jurisdiction. So just quickly talk about the equipment QC. Some of the aspects the physicist will look at, ensuring that the treatment planning system is accurately calculating the dose to a plan. Make sure that any treatment plans from the planning system are accurately being transferred to, say, the afterloader control unit. We'll make sure that we calibrate any new sources, whether that be seeds or a new high dose rate source. We will measure and try and detect any leakage of radiation from our equipment or afterloader. We'll check the safety interlocks. Things such as is the source being correctly emitted from the afterloader. Check things such as the dwell time accuracy of the afterloader, but also making sure the applicators that we're using for the treatment are not damaged. So that concludes a very quick whistle-stop tour through the aspects of brachytherapy that the physicist is particularly interested in, and I hope that was of some use and gives you some inspiration for further questions and research. So thank you very much for listening.
Okay, thank you, Mr. Andrew. Any question? Okay.
Good morning, Mr. Andrew, and good morning, my professors. I'm Dr. Christine. I'm clinical oncologist at Shams University. So my question is, what formula do you usually use to calculate the total dose after external beam radiation? Is it the BED or the EQD2? And secondly, is it built-in formulas in your planning system or what? And thank you.
Hello. Yes, good question. So we use the EQD2 to sum the brachytherapy and the external beam for the cervix treatments. The planning system doesn't do this automatically for us, so we have to. We have made a spreadsheet that we can input the doses from the external beam treatment, and then so for instance for the cervix treatments we are doing 4 fractions. So for every fraction we will put into the spreadsheet the new doses that we've given to the CTV and the organs at risk, bladder, rectum, bowel, and then it will sum, the spreadsheet will sum every fraction dose and convert into EQD2 for us. And then we report at the end of the treatment then to the total dose EQD2 external beam plus brachytherapy. But it is a bit of a manual process, having to come up with a spreadsheet. Yeah, it's not automatic in the planning system.
Okay, thank you. And my second question, what about patient treated outside your department? I mean, receiving external beam outside your planning system?
Yes. Yes. So yes, we treat the brachytherapy component for 2 other local external beam centers. So the way I approach this is I Before the patient comes to us for their brachytherapy fractions, I will contact the external beam center, and then they securely transfer a copy of the external beam treatment that they had in their local center to me, and then I will import that into our treatment planning system locally. We're using the same external beam prescription, typically for cervix, 45 gray in 25 fractions. The main issue that I'm looking at for the patients on the external beam is that if there has been any boosted volume to the nodes, say 55 gray, I want to make sure that that boosted volume isn't coincident with an area where the high dose of the brachytherapy treatment is going to be. So for instance, if the boost dose is over the rectosigmoid, I'll bear that in mind as the worst case scenario when I'm adding on the brachytherapy dose, that bit of the sigmoid could be getting the 55 gray rather than the 45 gray prescription. But in terms of looking at the other centers' plans, I will just import them into my planning system and evaluate the isodoses. If there are no boost doses, we tend to just take it as the external beam component to the HRCTV is the prescription dose. So in our case, 45 gray in 25 fractions.
Okay, thank you, Mr. President.
Thank you, Andy, for this. But do you mind if I add just, I do have a slide on my talk as well that just shows how DVHs are calculated, or the equivalent doses are calculated. It's the spreadsheet that you have done. But I think the one I had was only for 3 fractions, but at least it will give you an idea of, or the attendees an idea about what you meant by the spreadsheet. But yeah, I mean, the crucial point that you've mentioned is the fact that whenever there is a patient being referred to us from a different department, that we make sure that we do have access to their plans because of the concurrent boost. So it's not enough to say that, yes, they have given concurrent boost, we actually need to see it. And as you know, the case that we've done just a couple of weeks ago, although there was a concurrent boost, which you would have assumed that it was right in the periphery of the pelvis, it was actually impacting on the dose for the brachytherapy that we can give. So it's very, very crucial that this happens, that you review it. Thank you.
Now I would like to present Dr. Namat El Sayed from I'm sorry, it's not mentioned here from which university. She will speak about vaginal brachytherapy as an adjuvant treatment in endometrial cancer.
السلام عليكم, صباح الخير. It's an honor for me to be among you today to try to cover the vaginal cylinder brachytherapy, inshallah, as adjuvant therapy for endometrial carcinoma. Endometrial cancer is the 4th most common cancer in the woman. It's the main risk factor: obesity, nulliparity, tamoxifen, unopposed estrogen, and the protective factor like breastfeeding and physical activity. The FIGO classification, what is all the classification, is very important to know this because most of the trial of the brachytherapy based on this alt classification. And this alt classification is classified stage 1 into 3 staging. Stage 1A confined to endometrium, 1B less than 50% of myometrial invasion, 1C more than 50% of myometrial invasion, and 2B cervical stroma invasion, and 3A uterine cirrhosis, adnexia invasion, and or peritoneal cavity. The recent staging, which is 2009, this staging is divided only stage 1 and 2 stage. Stage 1A, no or less than half of myometrial invasion. So stage 1A is previously like stage 1A and 1B. And then 1B, invasion equal to or more than half of myometrium, that previously was stage 1C. And then stage 2, it includes all tumor invades cervical stroma, but doesn't extend beyond the uterus. And then stage 3 is divided into 3 stages. Stage 3A, tumor invades the cirrhosis of corpus luteum or adnexia. 3B, vaginal or parametrial involvement. And 3C, C1, which is positive pelvic lymph node. C2, which is positive para-aortic with or without pelvic lymph node. The management. The most of endometrial carcinoma is discovered early. So the main cornerstone of treatment is a surgery. The surgery is very important as a curative nature, but at the same amount is a main staging procedure, as the staging of the uterus is the surgical staging. The standard surgery for early stage is a bilateral salpingioophorectomy with the total hysterectomy. What about the lymphadenectomy? Which patient should undergo the lymphadenectomy? We should do pelvic alone or para-aortic lymphadenectomy. What's the prognostic impact? What the treatment modification based on this lymphadenectomy? And what the therapeutic impact of the lymphadenectomy? The role of lymphadenectomy is still controversial at this moment. The pelvic lymphadenectomy or multiple site sampling remains the standard procedure in the many departments, but except for patients at high risk of surgical morbidity. Randomized trials have failed to demonstrate any overall or progression-free survival advantage. Also, in low-risk patient doesn't have any benefit from the pelvic lymphadenectomy, which is associated with from 8 to 50% of the lymphedema. Step forward in the reducing the surgical morbidity has been removal of selective central lymph node, and this is trial of the freeze trial, which is mapped at least one central lymph node in 86% of the patient. Low lymph node detected in only 3% of the patient with the lymph node. So it has very good prognostic impact of more than 97%. The predicting lymph node, how can I predict the lymph node if it's positive or not before doing the surgery? The GOG 33, it has predicting this. If the patient has deep myometrial invasion with the grade 3, the risk of the positive lymph node exceeds more than 34%. Again, the prevalence of the lymph node depending on the tumor size. If the tumor size is larger than 2 centimeters with the invasion more than the half of myometrium, the risk of the lymph node metastasis exceeds 50%. So it's very important to know this, the depth of the invasion and the grade before doing the surgery. Doing the depth of invasion either from ultrasound or the MRI. And this is a nomogram for predicting the lymph node metastasis for presumed before surgery stage 1 and stage 2. In this nomogram, we put the age of the patient, and then we put the race, tumor grade, histological subtype, primary tumor size, and from this we can see how % of the lymph node positivity may be present. The efficacy of the systemic pelvic lymphadenectomy, this is addressed in the well-randomized trial by STEC. This randomized trial is randomized the patient if fit for lymphadenectomy or not. If not fit for pelvic lymphadenectomy, we proceed only for total abdominal hysterectomy, bilateral salpingioophorectomy. If the patient fit, we randomize it into 2 groups, standard surgery and the lymphadenectomy surgery. And this is a difference between the both groups. The 2 groups are actually, here it's found more than 700 patients, and again, this is 700 patients, good performance status. Time between diagnosis and randomization is most of the patient less than 6 weeks, and surgical technique is open in the both arm. And the most histological type found in this group is stage 1C, and the poor diagnosis patient that we have grade 3 patient. Results of this trial, of this randomized trial, was found that similar overall survival, similar disease-free survival, and better recurrence-free survival with no any statistical difference. So the criticism of this trial, nodal status not taken into account for second randomization, patient characteristic different in the two group, more deeper infiltration in the lymphadenectomy group and more grade 3, crossover done in this protocol, no systematic para-aortic lymph node dissection, and if the patient had positive para-aortic lymph node, still a question, should the patient receive external beam or not? A second trial with a systemic pelvic lymphadenectomy versus no lymphadenectomy in the early stage endometrial carcinoma. This trial include only stage 1 with myometrial invasion. It comes from 31 center. Para-aortic lymph node sampling or lymphadenectomy at this time of the surgery, bulky or more than 1 centimeter lymph node, it should be removed even if no lymphadenectomy are. And this is a randomization of the trial, include more than 500 patients, and the most of this median age of the post trial is 60 years. Most of the patient is a stage 1B or 1C. Regarding the results of this trial, it was found the patients, there is no difference again in the overall survival. The patient underwent no lymphadenectomy, it has 90% versus 85% with no statistical difference. So the theoretical benefit of surgical staging is use of nodal information to modulate our post-operative treatment. But what's the evidence support the use of adjuvant radiotherapy in the stage 1 and 2 endometrial carcinoma? The most of this trial based on these surgiclinical pathological features, based on the depth of myometrial invasion, cervical invasion, histological type, it's a type 1 or type 2 higher risk, which is serous clear cell or carcinosarcoma, what the tumor size, and if the patient has lower uterine segment involvement or no. The clinical trial in the endometrial cancer, it divided the patient into 3 stages. This according to ESMO guideline. We have low risk, we have intermediate risk, and we have high risk. We will address every group separate on each other. The low risk is a stage 1A, this according to all the staging, grade 1 or 2, histological type 1. The post-operative, this number first group is low risk group, endometrioid adenocarcinoma, stage 1A, grade 1 and 2. We have intravaginal brachytherapy in FIGO stage 1, low risk endometrioid carcinoma. This is controlled randomized trial. This comes from the many centers. For example, in the Tempura center, they use 5.5 gray in the 5 fractions, and in Istanbul, for example, use the 8 gray per fraction for 3 fractions. The characteristic of the patient is survival of the patient when compare if the patient received brachytherapy or no. We found no difference in overall survival. Regarding the recurrence, we have more vaginal recurrence in the no treatment arm versus brachytherapy. This is overall survival is more than 13 years, no difference in the overall survival. So the answer of our questions is the post-operative brachytherapy can be used? Yes, it can be used. No, sorry. The post-operative low-risk group, if speaking about if we have vaginal or no vaginal recurrence. In this study, we see what is the dose needed to decrease the vaginal recurrence. Found that no vaginal recurrence if using BED10 more than 30. BED10 is for tumor. If I give the dose more than 30 gray, I will not gain no vaginal recurrence. But if I give the dose BED10 less than 30 gray, I gain more vaginal recurrence 2.2. So the post-operative strategy for low-risk endometrioid carcinoma, stage 1A, grade 1, and grade 2, just to follow up. But take care, this is stage 1A according to all the staging system, not the new staging 1. Then we go to intermediate risk groups. This is actually most of our patients in this group. This is included stage 1A, grade 3, type 1, stage 1B, grade 1 or grade 2, type 1. If the patient after surgery should carry in follow-up or irradiation. Actually, this question will be answered by the following trials. We started with the first trial. This is oldest trial. This include clinical stage 1 after total abdominal hysterectomy with bilateral salpingoophorectomy. These patients will receive vaginal brachytherapy of 30 Gray low dose rate at the service, then randomized either the whole pelvis radiotherapy 40 Gray with midline block after 20 Gray versus no further treatment after the vaginal brachytherapy. The 5-year survival is equal in the both where no external beam or without external beam. The grade 3, which is the most important prognostic factor in this trial. So the conclusion, grade 3, more than 50% of invasions, this patient should receive the pelvic radiotherapy according to this trial. And all other patients with only invasions less than the 50% should receive the vaginal brachytherapy. Another trial, which is GOG 99, the eligibility criteria is include stage 1B, 1C, occult stage 2, after total abdominal hysterectomy with nodal sampling, the patient will randomize either pelvic radiotherapy, no vaginal brachytherapy versus no adjuvant therapy. If either the patient received external beam versus no therapy. And in this trial, we started to hear this is the new term, which is the high intermediate risk. This is intermediate risk, but high. What's the high intermediate risk? If the patient at least 70 years with other of the any risk factor, if the patient 50 years with 2 of these risk factor, or any age with these 3 risk factors. The 3 risk factor, high grade 2 or 3, invasion of the more than 50% of myometria and positive lymphovascular invasion. In the median follow-up of surviving patient, 20 months cumulative incidence of recurrence with only 3% in the radiotherapy arm and 12% in no follow-up in the no therapy arm and follow-up arm. The third trial, which is a PORTIC-1 trial. PORTIC-1 trial, the inclusion criteria stage 1, grade 1 with invasion more than 50% of myometria, grade 2 with any myometria invasion, or grade 3. The patient randomized again into no pelvic radiotherapy, whole pelvis, 46 Gray versus no therapy. Again, again we found that the no radiotherapy arm, it has more recurrence than the radiotherapy. 14% versus the 4%. And where is the side of recurrence? Mainly the side of recurrence is present on the vaginal recurrence. If patient doesn't receive any treatment, it will have high risk of the local recurrence, especially the vaginal fold. The PORTIC trial, which has more update of this trial, which is 10-year outcome. The local regional recurrence, again, there is a statistical significant difference between the both groups. The 15 years follow-up recurrence, we have 47%, we have again difference in the both arm, and we see 5% in the radiotherapy arm versus 15% in the no radiotherapy arm. And 74% of this recurrence will occur in the isolated vaginal recurrence. The last trial again of randomization of the more than 900 patients into no external beam versus external beam. The brachytherapy in this trial, it was 2 fractions of the 4 Gray at 0.5 centimeter from vaginal mucosa over 3 or 7 days, or low dose rate 15 Gray to upper 1/3 of vagina. The result of this trial, again we have isolated or pelvic recurrence 60% versus the 3%. And this is summary of all this trial. It was found that the difference between surgery and the no radiotherapy in the high intermediate risk group, there is difference in the recurrence in the all 3 trials. We go to another back questions. All the previous trials compare external beam versus no therapy. But this PORTIC trial, which is PORTIC-2, is a compare the external beam versus the head-to-head to the brachytherapy. It includes the patient more than 60 years, stage 1C grade 1 and 2, stage 1B grade 3, stage 2 grade 1, total abdominal hysterectomy without lymph node sampling. This unstaged patient randomized either to pelvic radiotherapy versus vaginal brachytherapy, high dose rate 7 Gray in 3 fraction, which is a common fraction used in this clinic, in our clinic, and the low dose rate is 30 Gray. In this trial, it was found only difference in the pelvic recurrence here, 0.5% at 5 years versus 3%. But there is no difference in disease-free survival, overall survival, and the progression-free survival. Again, regarding the toxicity, there is a statistical difference between the external beam and the brachytherapy. We found the grade 2 in 19% of our patients versus only 1% will develop the grade 2 toxicity. Regarding the quality of life, diarrhea and associated with the external beam is 22% versus 6% with the brachytherapy, decrease on the social function associated with the external beam. So the conclusion of the PORTIC 2, despite the slightly but significant increase the pelvic failure in the vaginal brachytherapy arm, distant metastasis, progression-free survival, overall survival were similar. The patient reported better quality of life after vaginal brachytherapy, so the vaginal brachytherapy should be treatment of the choice for patients with a high intermediate risk endometrioid carcinoma. The vaginal brachytherapy is sufficient for this unstaged population, 1B, 1C, grade 1 and grade 2, stage 2 and stage 1B. What the therapy for the intermediate risk group is the brachytherapy. We go to the treatment guidelines. As we see, the most of the here, if the patient has invasion of inner 1/3, it can be treated with a vaginal brachytherapy alone if had grade 3, and we have outer 1/3, grade 1 and grade 2 can be treated with the brachytherapy alone. So what is the clinical tips about the vaginal brachytherapy? It's easy like we saw before or not? We have pre-therapy evaluation. We should to evaluate the patient before go to operating room and start to selection the type of the applicator used. Pay particular attention to healing of the vaginal fold, if it's healed or not. It shows the applicator that is correct for clinical situation. The slender most commonly ranged side from 2 to 4 centimeter. Placement of radio-opaque sets or clips as a vaginal apex to be easily to be identified. Place the largest cylinder that fit comfortable inside the patient. Don't leave air between the cylinder and the vaginal mucosa. Try to minimize the movement from the placement and the planning and the treatment. And then we have here multiple shapes of the vaginal cylinder. Try to choose the size according to dimension of the vaginal cuff and the vagina. Try to choose which size possible, and the close contact between these applicators and the vaginal mucosa. Dose fractionation. The most commonly fractionation prescribed in our clinic, which is 7 gray times 3 to 0.0 centimeter, and at 5 millimeter depth is the most common prescribed fractionation scheme, but many sites can be used fractionations difference. Less toxic one is 5.5 gray given in the 5 fraction to 0.0 centimeter at depth, and it was prescription at depth 5 millimeters. And this is another also fractionations can be used at C4 gray 7 times 3, 5 times 5, 2.5 gray times 5, 6 gray times 5, all this at depth of 5 millimeter if the brachytherapy used alone. But if the brachytherapy used after external beam radiotherapy, you should prescribe this dose to the cervix only. The 100% should be described as a cervix, because the rectum is just posterior to vagina, and the rectum actually received the high dose from external beam, so to avoid the toxicity from brachytherapy, prescribe this dose as the cervix dose. And this is, for example, these are shapes of this is a vaginal cylinder, and this CT to see how it's fit inside the vagina. It should be fit like this, no air between the surface of the applicator and the vaginal mucosa. What the thickness and the prescription depth? What come from the thickness? What the mean thickness? I speak about just 5 millimeter depth. Where come from this point? We have 2 depths. We have standard depths, and we have what is called individualized depths. Individualized depths based on the patient. A standard depth, which is 5 millimeter if the patient didn't receive any external beam radiotherapy. After hysterectomy, this is a vaginal mucosa of the cuff, including, we try to include the scar, and more in 90% of the recurrent will occur in the cuff. And this, for example, this is a vaginal mucosa, is actually 19 millimeter, and this is a vaginal width. The vaginal width, it's important to select the type of the applicator, and this is a vaginal mucosa. Actually, this is the vaginal wall, which is red bar. This is a vaginal wall from 3 to 0.5 millimeters. This is a wall of vagina. And actually, this is our clinical target length. The upper 1/3 of vagina, we treated at this depth. And this is a clinical depth is 4 millimeter. So this is a prescription. It can be standard depths, as I said before. Vaginal wall it varied from 2 to 8 millimeter, but the majority of the case had adequate CTV cover and no excessive organ at risk. But we have some case, we have variation. There is no standard. What is this variation? Sometimes we have less than 2 millimeter, or maybe have more than 8 millimeter. So it means that some cases will receive either over treatment or under treatment. So in this case, we'll go to individualize it to determine depths. What that means that we have varying thickness of the scar. Some cases we have varying thickness of vaginal wall, and we have various positions of the organ at risk. How can I determine these individual determinations? It can be done either from clinical examination. I should examine the patient very well before doing the application, and also can be using by helping of the transrectal ultrasound, and also surgical and histopathological reports, and by image guiding. This is the best way. The best way is MRI. MRI of the pelvis, as we see here. This is a normal vagina, this is a vaginal cylinder, and this is a normal vaginal wall. Just is the 2 millimeter here posterior, while here at a 7 millimeter. So I need to increase the dose at this area, while to decrease the dose here posterior to avoid the overdose to rectum. Need to be imagined, if I prescribe the dose at a 7 millimeter, a large part of the anterior wall of rectum will be included. And if I prescribe the dose only at 2 millimeter, I will miss here the superior part. Another example of that patients sometimes maybe have cervical rest, or maybe have still remnant of this cervical stroma, this part. So it's very important to do MRI to be able to see what is the remnant behind you. So I am able to identify to what is called make individual plan. This individual plan, I actually make contour of the rectum, contour of the bladder, and try to make this isodose according to the organ at risk. And this is the standard plan. Again, this example of the individual plan based on the target volumes and the organ at risk. Okay. What the importance of this standard plan? We start the importance of these standard plans regarding the organ at risk. If I make a standard plan and prescribe the dose at 5 millimeter, we have risk of toxicity for vagina 34%, for bladder 10%, and for rectum 5%. But if I do individualized plan based on the organ at risk, I will find that the dose to vagina is decreased, the dose to the bladder and to the rectum is also decreased. No grade 3 or 4 morbidity, and no difference in the recurrence. So to conclude our lectures, the target volume post-operative brachytherapy, upper 1/3 of vagina, 3 to 5 centimeter, the size of applicator according to dimension of vaginal cuff, the close contact between applicator surface and the vaginal mucosa, 3D individualized technique is very important in some cases of variable anatomy, or if I need to prescribe the higher dose. Take-home message, upper vagina is the main site of local recurrence in the early stage uterine cancer. Vaginal brachytherapy alone for intermediate risk stage 1 uterine cancer is very important. We can combine with the chemotherapy if I treated the higher risk staging or type 2 endometrioid carcinoma. The vaginal brachytherapy dose specification 5 millimeter versus surface. The length of vagina is a variable. We actually take 3 to 5 centimeter. Applicator may be single channel or multiple channel. Treatment planning, we use 3D versus 2D. 3D allow for air gap assessment and normal tissue dose specification. Brachytherapy alone can be used in low risk stage 1 patient, has low impact. Intermediate risk stage 1-2 patient, it has very important role. Brachytherapy role, it has been increasing, particularly care, volume, length of vagina associated with a very low incidence of the complication. Thank you very much for your attention.
Thank you very much, Dr. Ahmed, for this educational presentation. Dr. Ahmed from Alexandria University. It's not mentioned here on my card. I'm very sorry, Dr. Ahmed, for when I introduced you. Any question or any comment for Dr. Ahmed? Yes, Dr. Ahab.
Thank you, Dr. Ahmed, for this elegant presentation. I have one question about is the lymph vascular invasion mandate to give the patient external beam irradiation even if it is grade 2 and 1A less than 50% endometrial cancer myometrial invasion?
No, the lymphovascular invasion doesn't mandate the external beam radiotherapy. Even in unstaged patient, يعني في البورتك ترايل 2 لما اخدوا البيشنت اخدوا معاهم البيشنت وي هاف بوزيتيف lymphovascular invasion وجم قارنوا بين البراكيثيرابي والاكسترنال بيم، ايوه هيبقى في فرق في اللوكا في البلفيك ليمف نود ريكارنس بنتكلم في 3% اكتر، لكن ستيل ما فيش فرق ولا في الاوفر اول ولا في الديسيز ولا في الريكارنس لو هي lymphovascular invasion. لكن وجود الليمفوفاسكولار انفيجن ده بيخلينا انديكيتد ان البيشنت دي تاخد براكيثيرابي. يعني لو انا جات لي بيشنت لو ريسك والريسك الوحيد اللي هتزوده للانترميديت ريسك اللي بنسميها بقى انترميديت ريسك هي الليمفوفاسكولار انفيجن، ده هيخليها انديكيشن ان انا امشي ناحيه البراكيثيرابي ما مشيهاش ناحيه فولو اب.
Thank you.
Thank you, Dr. Namet, for this comprehensive presentation. My question is about when to combine both external beam and volt application.
براكي مع external beam.
Yeah.
نمسك ستيج يعني اول حاجه ستيج 2 لازم patient all patient will receive external beam radiotherapy. This is according to NCN guideline. لو هنتكلم بقى في ستيج 1 لو انا عندي patient ستيج 1C فيها positive lymphovascular invasions فيها كذا ريسك فاكتور فيها 1C positive lymphovascular invasion old age more than 70 years لو في invasion of lower uterine segment can be combined both external beam مع brachytherapy. لو بتكلم في ستيج 3 حسب بقى يعني ستيج 3 ده is a big variety. لو البيشنت عنده positive pelvic lymph node هياخد كيموثيرابي وممكن معاه external beam، لكن لو البيشنت عندها positive pelvic lymph node وكان معاها كمان cervical stroma invasion ممكن combine the 3 modality يبقى combine الكيموثيرابي مع external beam مع البراكيثيرابي.
Combine chemotherapy with the volt application only?
لو هي جريد لو انا بتكلم مثلا سي كلير سيل كارسوما ستيج 1 ستيج 1 بي او 1 سي مع كلير سيل مع تايب 2 مش اندوميترويد كارسينوما بدي كيموثيرابي وبكمل بس الفاجينال فولد براكيثيرابي.
ثانك يو.
وانا اعتقد حضرتك ان هو حته ان انا ادي external beam irradiation هي معتمده على how much the incidence of pelvic lymph node involvement. لو زي ما حضرتك قلتي في الستيج 1 ستيج 1 سي جريد 3 بتوصل لحوالي 34%. In this case it is mandatory ان انا ادي external beam irradiation عشان البلفيك ليمف نود
وخصوصا لو هي اون ستيج يعني لو ما اتعملهاش اي سنترال ليمف نود سامبلينج هيبقى انا عندي ريسك اوف ليمف نود عالي اكتر من 50% من
فهي الفكره كلها هي قد ايه الليمف نود متاسس الاحتماليه بتاعتها وده اللي بيحدد external beam irradiation. شكرا.
Sorry, can I add something to this?
Yes, of course.
Thank you very much, Dr. Namet, for this. This is a very interesting talk. Very well done for it. I just wanted to add something about the new ESGO guidelines. So the new ESGO guidelines were published online in December 2020, and actually in the journal, the British Journal of Gynae Oncology, in January this year. So basically, the classification for low risk, intermediate risk, and high intermediate, and then high risk or metastatic has slightly changed, and this is by the consensus. So it's a consensus guidelines. It's not just one. So this is joint from ESGO, ESMO, and also another ECHO, I think. Yeah. So the three of them have joined forces to do this. The bottom line of the guidelines is the question mark about the lymphadenectomy or not. You're right. That is actually depends on the risk factor, but it's only valuable in the high intermediate. So this is when the changes happen. However, in the earlier stages, in stages 1A, 1B, even 2A, the fact that there is a lymphovascular space invasion within the myometrium, this is an indication for external beam radiotherapy, because these patients are unlikely to have been staged, and in terms of the lymph nodes, and even if they were staged, it would have been just sampling of the lymph nodes, which is the sentinel lymph nodes. And therefore, you cannot guarantee that the lymph nodes have not been treated. So, in fact, external beam radiotherapy answering the question about whether you should give it with lymphovascular space invasion, it completely prompts the staging. So things have changed and they keep changing, and it's so hard to actually keep our head around the regulations. And I totally appreciate that a lot of centers are not doing similar like each other. I think it's one of those areas in gynae oncology that are very tricky because they have been changing frequently. So the ESGO guidelines, again, when they were published, they're so complex. So in order even to follow it, it is so hard to follow it. I've just published in the same journal a commentary with a flow chart to make it simpler. And I hope that this actually reaches everyone, because it's now published online. I don't think it's actually been published in paper yet. And it is within the British Journal of Gynae Oncology. So hopefully it would be useful, because it's very hard to keep our head around all the changes. But it takes it into account, again, the P53 mutation, not, and so on. Thank you.
Thank you, Dr.
Thank
Huda.
you.
Thank you. Now I have the pleasure to introduce next speaker, Professor Dr. Huda Alpouz. She is a clinical oncology consultant with a specialty in head and neck and gynae oncology. The mic with you, Dr. Huda.
So I think my talk is recorded, actually, and I'll be there for the comments at the end, I think. Hello, this is Huda Alpouz here. I'm one of the oncology consultants in Bristol University Hospital. So I'm the lead for the gynae brachytherapy, and I wish to thank the team for inviting me to give this talk about intrauterine brachytherapy. I'm also very happy with the progress in Ain Shams University for setting up the brachytherapy service. I'm just going to talk today about intrauterine brachytherapy, because I appreciate other very eminent lecturers have actually given a talk on the endometrial post-operative brachytherapy. So just as a bit of a quick background before we go into the details, brachytherapy as used for cervix cancer is not only being used for the very extensive disease as some might think. In fact, it's being used for limited disease and also for the locally extensive disease. So with limited disease, I'm going to show you what that means, but it's basically those that are operable as well. But for medical reasons, you cannot operate on them. You can still do brachytherapy and the same format of treatment. However, we're going to concentrate about the advanced cancers within the central of the pelvis, which are extending into the parametrium, and therefore the need for sparing bladder and rectum and small bowel is essential in order to give that extensive dose, or much higher dose than you would be able to give for with the external beam radiotherapy. So just a quick background and a very limited and primitive diagram. As you can see here, there are first two stages, which is the stage 1A and the stages 2A as well. They're actually quite limited cancers that maybe not extend to 2A, but actually the 1A1 and 1A2, that you'd find that most of them are being operated on. Where we have to be very cautious that you really need to have staged cancers very well, because the last thing you want is them to be operated on, and then you need to have radiotherapy to follow that, because of the morbidity of having a dual modality of treatment. So it's really essential on staging accurately beforehand, hence the importance of having an MDT with the gynae surgeons prior to touching any form of therapy.
The rest of the ones that are the extensive disease ones are the ones that we're going to concentrate on our talk today. So the locally advanced disease, this is, extending from 1B2 to actually to stage horrible death, to be honest, if they're delivering a very high dose of radiotherapy is of value, even if it was for a palliative intent, because it's the horrible death, to be honest, if those patients have die of progressive disease within the center of the pelvis. Again, if there is no way that I'm going to jump into brachytherapy with all the image guidance without going through the very basics of brachytherapy. So this is how brachytherapy, to be honest, started, which is the Manchester system, having an intrauterine tube, having 2 colpostats in the vagina, and just a plain film that, in order to be measuring 2 centimeters superior and 2 centimeters lateral to the central tube, with the assumption that actually you're going to capture the disease within the limits. But how much does that tell you about? So how much that tells you about the extent of the disease realistically is actually very minimal. As you can see, it's a plain X-ray, plain film, and therefore it's very unlikely that you'd be able to assess whether you're covering the whole volume or not. And indeed, you can't actually tell if you're perforating the wall of the uterus or not. The position of the intrauterine tube will still be exactly the same, sitting proud in the pelvis, but actually it may very well be perforating the uterus. And I will show you some images later on about this, and you'll see how difficult this is to assess. So traditionally, as I said, it was a very standard way of examining patients, but in fact, you would not have been able to identify gross junior volume or defining any planning target volume, and it was basically a point prescription. So the point A, as you can see, this is the line for the point A. So this line goes, the prescription line goes through the point A, which really lies here, 2 centimeters above the connection between, so that the cervix flange, and 2 centimeters lateral on both sides. So it would stand there. So if you get a very big tumor in the center of the cervix, you're not going to cover it. You might say, well, actually, it's still getting a dose, but I'm glad that Professor Amin has given a talk before me on radiology, and would have been talked about the inverse square law. So that actually tells you that if you're not covering the prescription dose to those areas, then these tumors are not going to be covered well, because there's a steep decline in the dose gradient beyond that prescription point, because it's brachytherapy and it's high dose. So just as, again, for those of you who like diagrams, looking at it, this is the point A, and this is an audit showing the different shapes and shapes of cervical cancers. So not only that they may be very extensive, and therefore those, because of the steep growth, dose gradient, because of the inverse square law, will not be covered, but also those who have got very limited disease within side, and you're treating to point A there, then I'm sure you'll agree that you're probably frying the bowel and the bladder unnecessarily. And therefore, the move to image guidance has gone through. And if you look at the image, when you look at image guidance, we have used that in external beam radiotherapy, so there is no reason really, apart from the shortage of MRIs and CTs slots to be able to, and accessibility once you've got a patient that has got internal tubes in order to use it. So this was the whole idea, is to try to use exactly the same concept that you would use for external beam radiotherapy. So target volumes, as we all know, gross target volume, clinical target volume, and planning target volume. However, I'm going to cross this over because planning target volume isn't used in brachytherapy because of how, because you've got the applicator basically within the gross tumor volume, so there is no need for that to be within it. So the point A concept, we know how straightforward this would have been. The reason I've put that here is because when you're actually providing the service for a volume concept, for image guidance, you really need to make sure that your work schedule has changed and this has been approved by your management, because it will take the whole day. The difference between the two is that you're going to do MRI plus or minus CT or even CT scan. You're going to take time contouring. You're going to take time with the physicist will take time to reconstruct the applicators, and then the 3D treatment planning to be done. So this really takes a long time. There is an extra about 3 hours on top of this. So that needs to be acknowledged and taken into account when you're setting that service. Back to the uterine perforation, which I've talked about. If you would have done external, just conventional imaging with a simulator session in order to look at the intrauterine tube and the colpostats, you'll still see exactly the same images. When you do the CT or an MRI scan, you will realize that actually it is very possible that you've perforated a uterus without even knowing, because the straightforward X-ray films will not show you that. It's as simple as that. And therefore, ultrasound guidance in theatre is actually another very crucial point when you're setting up the brachytherapy service. It's very reassuring that you can see behind the bladder. So the ultrasound probe is not, we don't use it as a rectal here actually in Bristol, we use it as an abdominal probe, and you can see the bladder and the balloon and then the uterus behind it, and therefore you can see yourself coming into the vagina, the cervix, dilating the cervix and into the uterus. So it's very reassuring to do that before, rather than having those surprises after you've done the procedure. So back again about image brachytherapy. So the most often that was used was actually the conventional planning. Because it's very cheap, it's inexpensive, it actually does need, surprisingly, a lot of experience with it, because clearly you're not going to be checked in terms of other with other modalities, and therefore it does need a lot of experience in it. And also there is also the recommendation is to have all the MRI and the interstitial insertions, but this is very time consuming, it's very expensive modality, and there must be a way in between, and this is what I'm guiding the team towards, between this and that. Clearly we're not going to do that at all, but is there a way, if you don't have the facility to have MRI scans, in order to get at least to the pathway for that? So there is, and I think the majority of us has gone through it when we were setting up brachytherapy services. So the MRI scan can be fused to your CT scans if you only have access to CT. Yes, it can be helpful. It's not ideal. It's time confusing to consuming. I mean, to get the fusion done, and also the setup is very difficult, because the patient would have had an MRI scan on a completely different scanner, completely different bed and surface, completely different position, and therefore without even the applicators in, and then you're going to fuse it to a CT scan when you have the applicators in, so the position is different, the bladder fill is different, and it's very difficult to do, but it's doable. At least you've got the information from the MRI scan if you don't want to fuse it. The other option is to accept that not every time you're going to have an MRI scan. And this is, I think we've done this for a very long time. You can either do it at the first time so that you have an idea of what you're dealing with, or even at the last fraction, if you're using if you want to decide on doses and the extent of doses. The gold standard is this, and thankfully this is where we're at the moment, and we've been like this for years. So if you might ask you, why MRI if we've got access to CT? In fact, the CT is good because you can see the organs at risk. The only issue I would have with that is actually, which is a very major issue, is that you cannot see the tumor well, definitely on a CT scan. With contrast, without contrast, you will not be able to see it. So you can see the difference here between a CT and an MRI scan. I can tell that this is tumor. I can tell the wall of the bladder and the bowel. You can differentiate between rectum and rectosigmoid. We couldn't have done that with a CT. We can only say that this is bowel, but actually can't really define the difference between them. So it's quite of a good value, and it's a good step to try and move into, if possible. Another very important thing is documenting. How would you document what you have at diagnosis, at brachytherapy, what the patient had? It's always good to have a form, something that you could actually write things on and draw. So at least as colleagues, if you're aware and your colleague is there, they can know, they would tell what you've seen. So an example to this, you can here with the drawing of different colors, you can say, well, this is how the cervix looked. Actually, this patient had inner part of the myometrium being involved. You can tell that this patient had the upper 2/3 of the vagina being involved. So it's much easier than writing it. Drawing it, to picture it is very important. You've got parametrial invasion. On the right side, it wasn't as bad, but on the left side, it actually went into the pelvic side wall. So it's a very good language to use when you're actually handing over from one session to the other, even for documenting, even for telling the patient how well they did. So back to your planning volumes. The gross tumor volume is, as you know, always a macroscopic tumor that you can see at brachytherapy when you're doing the examination under anesthetic. And you can see that on the MRI scans, or if you don't have an MRI scan, you can translate that onto the CT scan. The high-risk clinical target volume is the gross tumor volume that you would see, plus everything that was normal within the cervix, and anything that you'd think that was a grey zone that may have been involved with tumor extension within the pyometrium. Now, the intermediate risk CTV, it used to be traditionally that we would use that as the tumor that used to be there before the patient had external beam radiotherapy. Now, that is not being used now. The way we're using it now, and this is internationally, that it's a centimeter around the HR-CTV, the high-risk CTV, and this is what you would use, because this is the one that you want to have at least 60 gray to the intermediate risk CTV. And I'll show you why we actually don't use the intermediate risk CTV as the previous, as the pre-external beam radiotherapy volume. And most importantly, to know that the brachytherapy, when you're actually dosing the brachytherapy, the dose is to the 90% at least of the high-risk CTV. That is the radical dose that you're aiming to, the prescription dose that you're using. So the reason why we wouldn't use intermediate risk CTV, for example, this patient had this tumor at pre-radiotherapy. Now, if you're telling me that you're going to draw this as your intermediate risk CTV at this very tiny uterus that she ended up with post-external beam radiotherapy and before she has her brachytherapy, then clearly you can tell why this has been stopped. So with this patient, you would have outlined this as the clinical target volume, the high-risk target volume, and then a centimeter around it just to ensure that you're sterilizing enough tissue around the high-risk clinical target volume. Another example, just with a drawing, that this is the gross tumor volume, and this is the high-risk CTV, so it includes this GTV plus all the normal cervix around it, and then the intermediate risk CTV, and that shows you in all sort of directions, and you can see it realistically here. The reason I've put this image in is just to show you that with this patient that we've shown here, this patient really doesn't have enough or any gross tumor volume that can be seen. You may argue there is a little dot here which we've drawn inside. So in fact, with this patient, we had to trim and pull in the prescription dose rather than as you would have done if you would have done to point A. In fact, you would have reached there because it would have been 2 centimeters above and 2 centimeters lateral, and therefore it would have been wider, and therefore your organs at risk would have had unnecessary high dose, which you could have done without. So this is very important to show you that actually it's sometimes the image guidance and having the MRI scan, it's even important that you can pull in the doses to save the patient from the late toxicity. So just going back to this, in fact, and I'm sure Professor Amin would have talked about the radiobiology talk about it, the importance of this when I say, well, you could save the patient from being treated for her organs at risk at a higher dose, because one of the things that you have to keep in mind that you are using a curable method for this patient. So it's not the end result at 3 months post-treatment that you're keen on only, but you actually need to always think about the quality of life for this patient for months and years to come. Because once they have the scarring in the bowel, because you've treated higher dose, unnecessary higher dose to the bowel, they may end up with no disease, which is good, but with intestinal obstruction because of the fibrosis, and therefore this is what you need to try and avoid. So this is just to show you how proximal, at the proximity of everything close around the applicator. So with all the programs now, with the high dose straight brachytherapy machines, there is a way that you could actually outline and see the DVHs for both the organs, both your volumes, the GTV, high risk CTV, and intermediate risk CTV. It's your aim to try and get them as shaped as possible, and also make sure that all the organs at risk are not being insulted by the doses. And nearly all programs also have got a spreadsheet that you can insert the dose that you've given for external beam radiotherapy, whether you've had a boost or not. Add this to all the fractions of brachytherapy, whether they're 3 or 4. This patient was 3 fractions, and then you could work out the dose that you've achieved radiobiologically. So it does have a built-in radiobiology calculator that would actually do it, instead of you struggling to calculate each one. One of the things I'm very keen on is to try and avoid having the disturbing trend that's happening, which is boosting, because it's much cheaper and much more accessible to actually boost with external beam radiotherapy, whether this is proton beam, SABR, IMRT, VMAT, whatever. I think we need to avoid doing that, and really brachytherapy is essential. It is really essential that all departments should have it, or if if departments near you have it, you can refer patients to them rather than doing external beam radiotherapy boosts. And this is actually a very clear picture to that, because there's unnecessary doses to the other organs around. It's nothing like a very shaped image-guided brachytherapy, which is very neat and very small, and because again of the gradient used, the sharp gradient drop in doses, it's very important. So, and you know, this is not just me estimating it, but in fact, since 2013, with this publication, we know in the International and the Red Journal, we know that no brachytherapy causes 10% reduction in survival. If you do it image-guided, you actually add another 10% on top of that. So it's actually worth fighting for. Image-guided brachytherapy, there was an audit in 2008, and I'm sure around the world was very similar, that it was only 4% of centers that were using MRI scan at that stage, and most of them were using 2D conventional. However, the latest audit was 2015, and we're still waiting for another audit, that actually there was nobody using the 2D radiographs. Then the majority were using MRI scan. I'm glad to say that Bristol was one of the centres that were not using were actually using the MRI scans at that stage, and since then, and even before that, we've been using it for the 4 fractions. So just a couple of cases that I'm going to put across here, just to show you that there are things that are really achievable once you have got the right applicators, the right skills, and the right images, and the MRI scans, and really having expert physicists that could actually work with you and really try and achieve the impossible. So this is, for example, a patient that was presented to us from another center who, before external beam radiotherapy, had a large tumor in the vaginal vault, together with a large tumor that was actually attached to it. Sorry, this was pre-radiotherapy. It was all one tumor, and after radiotherapy, she's had a separate volume here. It separated, those two volumes separated than each other. So clearly that node wasn't boosted with external beam radiotherapy because it was all thought to be the same tumor, but then when she's responded, it was found that actually they separated from each other. So this is what we were faced with when we were doing brachytherapy. So what we did is we've used, this patient didn't have a uterus, so actually I've removed the intrauterine tube, which is here in the center, but used a multi-channel applicator with an interstitial holes so that you've got the interstitial needles going through it, and managed to put the cylinder in and the interstitial needles inserted all around, but one needle or a couple of needles managed to get into that tumor there. So we're still waiting to hear if this patient, because this was quite recent. Another challenge, and this was actually about 3 years ago, this patient has had a hysterectomy for a cervix cancer. It was a limited disease. She had no lymphovascular space invasion. It was very limited. That actually the patient that she didn't need adjuvant treatment. Unfortunately, a year later, and we have reviewed the previous histology, she definitely didn't need any adjuvant treatment. Unfortunately, a year later, she presented with this. So this is the vaginal vault, and then she's got a huge tumor, about 5 by 6 centimeters, sitting right between the bowel. Given that the patient did not have radiotherapy in the first go, so we gave her chemoradiotherapy 5 weeks. Unfortunately, very limited response. So she's had, the tumor has, gone down to 4.7 by 3, so about 4 centimeters. So really 4.5 by 5 centimeters by 4 centimeters, but still attached to the bowel, attached to the vagina, really hugging the back of the wall of the bladder. So we really had quite a serious talks with the patient, to consent, and and we discussed in multiple multidisciplinary team meetings to see what we should do. The options were either exentration, which the patient declined, or that you actually stop and give chemotherapy. And again, I don't think it was a good idea, because the patient had no lymph nodes, no disease, no distant disease, but just left with this. So we went on with interstitial brachytherapy, and this is just to imagine where the tumor is. So we've used this as a template. This is not a device. There isn't sort of a it's not an intrauterine tube, and just a plug here, interstitial stump, and it's got holes for interstitial needles. So we've used that, put it in the vagina as high as we can, and interstitial needles through this. And I'll just remember that obviously the dose we've used was sufficient to treat the cancer. However, one of the things I need to remind you, again referring to the radiobiology talk that you've had, that we're not only keen to avoid high dose to the bowel because of the acute toxicity, which you see when the patient is having treatment and for the first 2 or 3 months after having treatment, because that is a reaction from the lining of the bowel, which shares the alpha beta ratio with the tumor as alpha beta ratio 10, but actually the worry is the lining is actually the outer wall of the bowel, because that consists of fibrous tissue, and therefore alpha beta 3, and therefore months and years later this patient may present with intestinal obstruction. So the doses were given, sufficient doses, and this is the plan. We knew that we are compromising the bowel, but for the benefit of curing the patient from the cancer, we went for it, with the understanding that if we were to struggle with any bowel issues or any fistulae that avoid, then in that case the patient would have a colostomy, and she's agreed to that, but she wanted to try and go ahead with this. So anyway, 3 months later, this is the tumor, really a very marginal response. And then interestingly, 4 months, 6 months, so actually it's a delayed response. And you can see here at 6 months, there was nothing seen. Were very impressive results at that point, because there are some cancers, although this was squamous cell carcinoma, but there are some cancers that do have a delayed response, so don't give up on the patient. And this is 12 months after, and this is 24 months after, which is really impressive and very happy for the patient. The only thing that I would need to say is that this patient, I warned her so that she doesn't get alarmed, that months and years, and she's now 2 years post she's now 3 years post completion of treatment, into her 4th year. If she gets constipated, she will bleed rectally, because obviously all this has been insulted by the radiation. Also, she does get repeated UTIs. So she's on low-dose antibiotics and now stopped, in fact, and this is absolutely settled. She's very cautious about being very well hydrated and making sure that she's not loose in terms of, she's always loose so it doesn't get constipated. And she's managing really very well. So it was quite impressive, as I said, with this. So that's the end of my talk. I'd be very happy to it's actually, as you can see, but I'd be very happy. I'll be attending the conference to take any questions regarding this talk, and I'm hoping the rest of the panel are going to be there as well, so we could talk about any issues with radiobiological queries or planning queries. And thank you very much for listening.
Thank you, Dr. Huda, for this nice, valuable lectures and talk. Is there questions from the floor? Actually, I had 2 questions for you, Professor. The first, you have a lot of applicators, cylinder and tandem with the pores for interstitial.
Sorry, I can't hear you very well.
Do you hear
it's
me
not
now?
loud enough.
Do you hear me?
Sorry, can you repeat again? Yeah.
Okay. First, thank you for this nice lectures. I have 2 questions for you, Professor. The first, you have a lot of applicators, tandem and cylinder with pores for interstitial needles, mold and pores for interstitial needles. We have tandem and ring and tandem and cylinder. Along of this set of applicators, is there certain applicators have the chance to give little dose for a rectum, and you prefer it, and how you select your applicator?
Sorry, an applicator preferable for what, sorry?
How you select your applicator along this variety of applicators?
Yes.
And is there a certain form of applicators reducing dose to the rectum? The second question is, what is your recommendation for patient to improve quality of life after brachytherapy? Is there certain exercises, local measures?
Okay.
Thank you.
So thank you very much for your question. Can you hear me well? Because I think the sound after the recording was a bit low. Can you hear me well?
Yes, I hear well.
Okay. So basically, the reason we have many applicators is because we've started off with you know, we're talking about 15, 20 years here of experience during the high dose rate brachytherapy. So what we started is, like most centers, only with a colpostats rather than a ring. And in fact, the build-up of different applicators coming, this was actually every few years, if something comes up new or we're stuck in a certain case that we find that we can't use our applicator in it, then we started trying to shop around to see if we can actually, not shop around, because our system is varying. I mean, you know, so we just go and approach them and see what other things, other applicators that are there. So it's not deliberate that we've got many applicators, although in the last probably 3 years, I would say, once we've started getting, so we've had the ring and tandem, and we've had interstitial needles to use in the ring. Once we get more and more confident, it was very clear that there were cases that you needed different applicators that you can use, and you can always use without a template or a guidance, and you can always use free needles. Although rightly so, our physicists don't like the free needles because they're very difficult to track and to make sure that you're definitely knowing where the needle is. Despite doing a CT and an MRI scan, you may not be sure. And you have to be very, very sure where the position of these things are, because otherwise, if you just imagine it or assume where it is, then you're, you know, with a high dose rate, you're probably frying the tissues, so you can't really do that. The question about using what to use in order to protect the rectum, we don't use the rectal applicator that pushes the rectum away. It's in fact all by manual packing. So because we study the scans very well before any procedure, what we would do is know exactly whether we need to put more packing posteriorly, anteriorly, between the, you know, or shouldn't actually be even packing at all behind the bladder if there is bladder invasion. So these things you really need to assess, but it's all about pushing gauze around the applicator and tucking it either behind it in order to push the rectum out of the way, or to put it also anteriorly to push the bladder out of the way. It all depends on what you can do perfectly if you use all around, but clearly you have to know if the patient, after you've examined the patient clinically in theatre, not just depending on the MRI scan that you do at week 5 of external beam, if you know that this patient doesn't have an invasion down the vagina, then in that case, it's important to pack that area, because you actually need to treat it. When you say when you choose and what according to what in terms of the applicators, I think the only thing that I would say is whether there is vaginal involvement or not. Most ring and tandems or colpostats are perfectly fine to treat the top 4 centimeters of the vagina, I would say. But if you've got a disease tracking lower down the vagina, and we've done a few of these patients that have had residual disease right lower down the vagina, there is no way you're going to be treating this with a standard applicator. And this is when the multi-channel cylinder with the tandem in it to be used in order to be able to load lower down. And better still, if it's a multi-channel or interstitial, in order to you get needles into the cervix as well.
Yes.
So, and I think your second question.
Quality of
sorry,
life
what was
of the patient after brachytherapy?
There was a second question I think you asked me.
How to improve quality of life for the patient of brachytherapy?
Oh, the quality of life, yes.
Yes.
So in terms, if you're referring about the, in terms of vaginal health,
Yes.
if this is what you're referring to, then I would say, so what we do is normally these patients, and in fact, not just the brachytherapy patients, so any patients having external beam radiotherapy, vaginal brachytherapy, radiotherapy to the rectum,
Yes.
these patients that have the vagina being involved, our radiographers are trained to talk to the patients about using vaginal dilators after finishing treatment. But usually we ask them not to use it until I've examined them at 4 to 6 weeks after finishing treatment. Check that these patients have actually healed very well before going ahead with using the vaginal dilators and inserting the vaginal dilator with some gel around it, and they talk about it. And it's not mandatory, but we offer it to the patients, especially those who are not sexually active.
Yes. Thank you, Dr. Hoda. Thank you very much.
I have a question for you, Dr. Hoda, and for Mr. Andrew Brown, for both of you. Regarding the spreadsheet of the submission of brachytherapy and external beam radiotherapy, what I understood is that you made the addition or the submission in different points. But do you think is it easy to find out a solution for performing the submission in 3D?
I think I'll leave this for Andrew to comment on it, but I must apologize. I think I mentioned in my talk that this is built in the planning program. I must admit it was done perfectly by our physicists, that I was fooled to think that it was actually done by the variant team. So thank you very much, Andrew, because I did think that it was actually provided by our brachytherapy providers. So this spreadsheet, but I'll leave Andrew to talk about it because he's more experienced in
Is
that.
he still with us?
Sorry, you're very, very quiet on my sound, and I can't quite hear. Could you just repeat what you want me to answer?
Sorry?
So I think Professor Amin, there is a problem in the sound from your end after they've stopped the recording.
Shall I repeat
Because
my question?
I can hear Andrew very well. And
Can you hear me now, Mr.
but
Andrew?
We can't hear you from the floor.
He doesn't hear me?
No, it's very quiet.
Very quiet, very, very quiet.
It was very good at the beginning. We've heard everything, but until my thing have actually finished, it became very quiet. So if you've got someone from IT, it would be great if they can just adjust it, because it's not the same setup as the beginning when we first started.
Yeah. Okay. Shall I repeat the question now? Can you?
Yeah, that's brilliant.
Yes,
Okay.
better.
Regarding the spreadsheet of the brachytherapy and the external beam radiotherapy submission, I think that spreadsheet is performed for point doses in different organs. But do you think is it easy to solve the complication of adding the two methods in 3D?
Okay, so we are doing 3D. We're not reporting to point doses. We are, for the organs at risk, we are taking the dose volume information from the external beam plan and the brachytherapy plan, and for the target. So with the brachytherapy, we are looking at the 2 cc, the 2 centimeter cube doses for the organs at risk, because they are the hottest part of the organ, and we're concerned about fistula and the like with brachytherapy doses. So we take the dose volume information from the planning system, and that is the information we're putting in the spreadsheet that we use. So we're taking the planning system's dose volume information, but then we manually do the conversion into the EQD2 doses that can then be summed between the external beam and the brachytherapy. So it is a volume dose. So for the organs at risk, we're looking at the 2 cc, the hottest dose of the organs, and we are reporting on the high-risk CTV to the dose to 90% volume of the organ. That's the reporting that we're doing.
Yeah, I'm sorry, Professor Amin, I've misheard your question. Yes, so the spreadsheet, although it does have the point A on it, but this is just to record it, but the prescribing is actually to the HRCTV D90, and we report spreadsheet has got when Andrew says that it's manually calculated, well, it's actually it's fed into the Excel sheet so that it does the calculation manually. It does the calculation as an equivalent dose, and then you could work out the rate, the doses and so on.
Okay. Thank you very much, Professor Hoda. Thank you very much, Mr. Andrew. Any more questions? Yes, Christine.
Good morning, Dr. Professor Hoda. Hope you can hear me clearly. I'm Christine, and first let me thank you for this more than perfect, highly illustrated lecture. My question about operated cervical cancer patients with a positive margin. Would you provide those patients brachytherapy after external beam radiation or not? And if yes, what will be the HRCTV for those patients? The same as endometrial cancer with a vaginal cylinder or what?
That's a very good question. So yes, if there is a positive margin, what I would do is do an MRI scan first and check that there isn't actually residual disease, because you have to be careful with these patients. Normally they fly through the system very quickly, so the surgeons would have actually imaged them and then did the surgery, and all you had was actually pathology to say that this patient has got, for example, a positive margin or extensive lymphovascular space invasion and a high-grade disease. So in these patients, depending on when you get these patients, please do MRI them before you actually subject them to either external beam radiotherapy or brachytherapy. And if there is nothing and you're purely treating them because they had a positive margin or lymphovascular space invasion and so on, then yes, using a standard cylinder would be the right thing to use after the external beam radiotherapy. So, and loading 3 centimeters to treat the top 4 centimeters is absolutely fine. It differs if you did have residual disease. In that case, you are treating the patient as if you're treating a radical cervix cancer. So clearly you could still, clearly you don't have a uterus to use a tandem, but you've got the multi-channel applicator. I'm sorry, I can't remember what you called it there. So the multi-channel applicator, and you can do it as a plan. So you can do a CT scan and mark the volume and do it as a planned thing. And actually, Namet has actually talked about it as well. She had a bit on that. So this is like a normal plan. So you do the external beam radiotherapy, do a week 5 MRI scan, and then load the vaginal cylinder depending on the thickness of the disease, the residual disease that's left.
Okay,
I hope that answers your query.
Yeah, thank you, Professor.
Any more questions? Yes, Dr. Ahab.
Thank you, Dr. Hoda. Just I want to clarify a point back to our early discussion about prostate cancer. In maybe 10 years before, they usually give, if they give temporary iridium implant in case of cancer prostate, they use it to give it, if it's combined with external beam radiation, it will give it before external beam radiation. And the reason for that, first of all, it is given guided by transrectal ultrasound, so it is better, it is easier to use the transrectal probe before in the rectum before external beam radiation, that use it after external beam radiation with toxicity from external beam radiation. Second, sometimes there is a change in geometry and in the vascularity of the prostate after external beam radiation, so it is to be very difficult to implant the prostate temporarily with the iridium if give it after external beam radiation. So they used to give it before external beam irradiation, then after a while they give it external beam irradiation. This is what I saw in USA, for example. So they give it before external beam irradiation, not after external beam irradiation. If they use iodine, a permanent implant, usually, and if it is combined with external beam irradiation, which is rare, they give it after external beam irradiation. This I want just to clarify it. Thank you.
Yeah, no, that's fine. I mean, you know, it's from our practice here, and this was a long time ago because this is no longer being used. The low dose, as you know, in HDR is being used now. But from my experience, actually, because I used to do prostate brachytherapy before, when we did that, it was actually only as when you're giving it for early prostate cancer, which you don't need to use external beam radiotherapy as well. But yeah, I mean, if you've used that before, that's absolutely fine. I mean, but normally with the low dose, the low dose brachytherapy, it's used for the very minimal, the early detected prostate cancers, and it's used as a sole treatment. If there was any boost, it would have been boosted with either external beam radiotherapy, but nowadays it's actually high dose rate brachy.
Can I just add, Hada? So with our high dose rate prostate protocol currently, with the iridium high dose rate, we currently do, like you say, 15 gray to the prostate first, and then they would have external beam after that, and as a combination. But for the lower risk patients, we would use a 19 gray to the prostate as a monotherapy alone. And we have also, in recent years, also used a single dose fraction of 19 gray as a salvage treatment after failed treatment. So that's our current HDR protocol in Bristol.
Yeah, but that with the HDR.
Which HDR? Yeah. With HDR.
Yeah. Thank you.
Dr. Hoda, thank you for your nice presentation. Amati speaking. My question about the residual disease after the brachytherapy. Actually, when we finish the brachytherapy, we will wait for 4 weeks to 6 weeks, and then we did MRI. And after that, we find either complete response, complete radiological response, or we find partial response or stable disease. In case of the complete radiological response, how to be sure that is a complete pathological response at the same time? Because sometimes when I get complete radiological response, I ask the patient to follow up, and then after 3 months, I found the recurrence of the lesions. So how can I be sure that is complete radiological, is a complete pathological? And again, regarding the partial disease after the external beam brachytherapy.
Can I just answer that question? Because I tend to forget the other question afterwards. Okay, so just the first question about the staging. The staging MRI post completion of treatment. I would say that the guidelines here in the UK, and that's the Royal College, and also the JEC Estro, initially it was to scan 3 months after, not the 4 to 6 weeks. And the reason they've stopped doing that, and it used to be a very long time ago that they used to scan, as you say, 4 to 6 weeks. The reason we've stopped doing that is because whatever you see at 4 to 6 weeks is probably an interim. And as you can see from the case that I've shown you, the patient in fact had, continued to respond, and it just to stop you acting on a residual disease that's probably going to go if you're patient, just leave it. So I would say delay the scanning to 3 months. In fact, there was a recent in fact publication. I can't remember. I think it was from the Jackie Estro group that they were actually even suggesting that we scan at 6 months rather than 3 months. I must admit I haven't done that. The reason I haven't moved from 3 to 6 months is exactly what you're telling me now, is if you have a residual disease, and that residual disease is very confined to the cervix with no parametrial invasion, it may be very possible that the surgeons could operate by a simple hysterectomy, not a radical hysterectomy. If you leave it too long, if you leave it at 6 months, if they try and operate, it will be very, very hard, because you have, as you know, the late effects will kick in, and then you'll have all the fibrosis and so on. So that's the reason why I would say that you wouldn't do that earlier. So that's my question. I think that's my answer. If your question, how would you guarantee it? I wouldn't subject, if there is nothing that you can see radiologically, I wouldn't go on and do an examination under anesthetic and do a biopsy, because where would you biopsy? There is no, you may biopsy the wrong area if there is nothing to be seen. But all I can say is probably you're doing the MRIs earlier than usual. It's better to delay it to 3 or 4 months post-treatment.
Okay, but if I found residual disease after 3 months, actually,
then you do an examination
at the setting,
under anesthetic
at last
and a
setting
biopsy.
of, yes.
If that becomes if that's positive, because sometimes radiologically it's the other way around. Then because radiologically, whatever is residual, it might be actually fibrous tissue, and it's misinterpreted by the radiology. So you would do an examination under anesthetic, then a biopsy. And if the biopsy is positive, then a PET CT scan. If the patient has no evidence of disease elsewhere, then in that case, if this is operable by simple hysterectomy, then the surgeons can do it. If it's not, then unfortunately, this patient is heading towards exentration.
Dr. Huda, excuse me,
Yeah.
would you recommend to do PET CT from the start to assess our
PET CT is mandatory from the beginning. So as a mandatory in terms of staging nowadays in order to stage. So the reason I'm saying nowadays, because actually until 3 years ago, the standard staging before starting treatment would have been a CT scan. But now it's PET CT, and that's because of the missed lymph nodes that you may have actually seen a pelvic lymph nodes on MRI or CT, but not realized that there are actually avid nodes at in order to track with your external beam radiotherapy. So a PET CT at the beginning. To do a PET CT at 3 months, I wouldn't subject everyone to PET CT at 3 months following treatment.
Yes.
I would only do it if there is residual disease.
Okay. Thank you, Dr.
We tend in the UK, actually, we use the PET CT far less than we do in Cairo. And that's because of the radiation exposure, to put it lightly. So.
I think it will be not to waste the time. It will give us activity of the residual once after 3 months after treatment for brachytherapy.
Well, the MRI is enough. I think if there is residual at the MRI scan, in that case, do a PET CT, because what you want to know is this is salvageable or not.
Okay.
But subject everyone to a PET CT. A, it's expensive. B, the radiation exposure, I think it's 10,000 times the CT scan. Maybe actually Professor Amin, if he's around, he might tell us. But it's.
Okay.
I think it's thousands more the exposure from a PET CT than a CT scan, or from, you know, and clearly the MRI doesn't have any exposure anyway.
I think we can apply the same rules as in in a carcinoma, as long as because sometimes it is very premature and very early to assess the patient after 4 to 6 weeks. We have to wait at least for 3 months, and if there is no progressive
Totally
disease
agree, yes.
and clinical symptoms, we can wait more as long as there is no progression in radiological progression or clinical symptoms, and we can stay more because the response can take very long time. And then, so as in a carcinoma, we can wait up to 6 months before going to biopsy or PET scan. Thank you.
I totally agree. And you'll find that you're actually saving lots of patients a lot of morbidities from all the biopsies, and the surgeons will just jump in really. So I would say, yes, you're absolutely right. Absolutely.
Okay. In the end, we want to thank our guest speakers from Britain, Mr. Andrew Brown and Dr. Hoda Al-Bouz. Although we always consider Dr. Hoda Al-Bouz as one of us, she's not a guest.
She is not a guest. She is visitor professor in Ain Shams University now.
Yeah.
So it is still one of our members. In the
No, she's a member of our family anyway.
I never leave home, yes.
And I want to ask all chairpersons and all the attendants and the organizers, of course, for this great conference. And thank you very much for all of you.
Thank you very much for giving us the opportunity. Thank you.
Thank you very much.
Thank you.
Thank you, Mr. Andrew.
Thank you.